All right, so hey everyone. For those that don't know me, I'm Adam Rothman. I'm one of the pulmonary and critical care attendings here at Mount Sinai West, and also the associate program director for POCUS. So this is sort of the second in a lecture series where we're trying to add some didactic sessions to the academic half days regarding point of care ultrasound. Obviously for those who have done the ultrasound elective or have a background in ultrasound, whether it's prior training, this may be a bit of a review. But it doesn't hurt to hear things and see things more than once. So that being said, we're just going to broach a very narrow topic and today, where I'm just going to go over the ways that we sort of evaluate and assess LV function at the bedside. It may be different than what obviously the cardiologists look at, and so I'm going to go through just a series of samples and discuss how we sort of describe something as either hyperdynamic, normal, reduced, or severely reduced. And then, for the second half of the lecture, we're sort of just going to be running through a series of clips where I would love your feedback. Obviously this is via Zoom, and it's hard to learn ultrasound via Zoom. So what we're going to try and get you guys to do is sort of answer your thoughts through a series of polls, and then we'll work through and we'll discuss your answers as we move forward. So getting right to it. Just in terms of the basics of LV function. So obviously for point of care ultrasound, it's a little bit different than your formal transthoracic echo measurements. We really only categorize LV function in four real ways. And so hyperdynamic, normal function, reduced, or severely reduced. We're not, saying estimating, EF at 13% or 78%. These are really just our overarching assessments based on what we can see in our four views. But that being said, you can gauge more nuanced determinations of ejection fraction, diastolic dysfunction, mitral wall motion abnormalities using additional training, and obviously, in the formal echocardiogram. But we won't really be discussing that right now. So as you guys might know from the basics lecture or from your prior experience in the ICU, this is our classic parasternal long axis view, and this is one of our main views for assessing LV function. And again, it's this we sort of look at the point of view of the heart along the left sternal border. Usually second or third intercostal space. Sometimes you have to go a little bit further down depending on the patient's body habitus. And we're really assessing the LV function in three different ways. So the first of which is looking at how the walls are thickening with contraction. So you can kind of see with contraction the change in diameter of the wall. You're also looking at how the cavity size is changing with each contraction. And then the third way, in which I tend to think is the sort of the easiest thing to spot, is the movement of the anterior leaflet, which is right up here, as it's going up towards the septal wall. And with normal ejection fraction, generally this anterior leaflet should at least pass the midway point. But obviously there are some other indicators to suggest whether something's normal or hyperdynamic. And so going along with looking and focusing sort of on the anterior leaflet of the mitral valve, we sort of use the E-point septal separation, EPSS. And what that's doing is it's really just focusing entirely on the mitral valve as it moves towards the septal wall. And what you want to do is, once you have an adequate parasternal long view, you want to move the view slightly so that the anterior leaflet of the mitral valve is in the center of the screen. And then once that's in place, you're going to use your M mode, which again stands for motion, with the line of the M mode sort of at the level of the tip of the mitral valve. And basically what you're doing is you're assessing, by doing this, you're going to be assessing the tip of that valve as it moves towards the septum over time. And what we can do while, after you've obtained sort of a clip of M mode and freeze the image, is you can measure the distance of the tip towards the septum. And so classically, in at least normal or hyperdynamic LV function, it should be within 7 millimeters of the septal wall. If it's 7 to 10 millimeters, that's sort of your gray zone indeterminate. And certainly if it's more than a centimeter or more than 10 millimeters from the septum, that's suggestive of reduced LV function. And so I just provided, a quick example here of, obviously this is not a video, it's sort of just a snapshot, but you can see here very clearly the septum is labeled here. You have the mitral valve, right? So the anterior leaflet is the one closest to the surface of the skin or closest to the probe. That's why it's called anterior. And then the E-point septal separation. So this is sort of the distance we're measuring in our M mode setting. And you can actually see, these sort of peaks and troughs. This is just the movement of the tip over time. And then this layer here is a septum. And so here the distance measured is 18 millimeters. So this would be a patient that I'd be worried about might have reduced LV function. And then from there, I'd probably use some other cardiac views to try and see whether, I'm right or wrong. And so how else do we assess sort of LV function? So the main view I would say that we sort of do at the bedside, where we can really get a good view of the main aspect of the left ventricle, is by rotating the probe from the parasternal long axis 90 degrees. And then that gives us our parasternal short axis. So again, just to jog your guys' memory, right? So the left ventricle is right here in the center of the screen, right? It's a nice donut shape. And then the crescent shape above is sort of the right ventricle. And then the septal wall is right here. And then you really want, when you're assessing LV function using this view, it's best to evaluate at the level of the papillary muscles. So that's what you really want to be able to see, your boxing gloves coming in at, usually it's like 5 and 7 o'clock. It could be 3 and 9 o'clock, but you want to see these boxing gloves because that's sort of the mid ventricle. It gives us our best indicator of really helping us analyze. And what I like to do is I like to stick my finger on the screen. Now that on PowerPoint, it's a little tiny finger in the center of the screen. But basically you use this because you can see, if there's even any regional wall motion abnormality. So if the septum is moving in more than sort of the other lateral wall might be moving in. So this would be one way you can at least assess regional wall motion abnormalities. And then in this view, you can kind of guesstimate LV function as well by looking at how much the diameter of the left ventricle changes over time with contraction. So for something to be suspected normal ejection fraction or better, you want the diameter to decrease by at least a third, right? And that's just sort of like, if you think about your basic, going back to your area of a circle, right? Pi r squared. So if your original radius is 3, right? The area would be 9 pi. But if your radius goes from 3 to 2, then your area will be 4 pi. So, going from 9 pi to 4 pi would suggest a decrease in area by over half. So that would probably be something that's normal. So the 1/3 change in diameter, at least for normal LV function. If it decreases by more than a half, that might be indicative of hyperdynamic LV function. The other thing that this view tends to be useful for is in the detection of cardiomyopathies, right? So, and what we're doing here is we're really paying attention to the wall thickness. And you want to pay attention at the septal wall or the free wall and look at how the diameter changes over time and really measure it at the timing of end-diastolic LV diameter. So what you can do is you can sort of freeze the image and use your calipers or measure button to delineate the distance. And normal thickness, you want it to be around between 6 to 12 millimeters. And then you can also look at the diameter of the left ventricle itself, and the normal numbers for that is 40 to 60. It's not something that I would generally do at the bedside POCUS, but this is sort of if you have time and you're interested and you're really trying to decide whether a patient has hypertrophic cardiomyopathy, for example. That's something you could do and do a little bit more focused view. Now if you're not sure, if you're worried maybe the patient has like Takotsubo's or some other issue that's mainly localized to the apex, then if your best view for really detecting something like that is going to be with your apical 4-chamber. This I think is the reality of the apical 4-chamber view, meaning that not all views are great. So this is actually a 5-chamber view where you have your left ventricle right here in the center. Your right ventricle is hiding over here. There's actually your aortic valve and aortic outflow tract, and you're not really getting an ideal view of the atria, maybe the mitral valve here. But the reason why I use this clip is I really wanted to highlight sort of the apex of the heart and compare it to what's going on closer to the mitral valve and aortic valve, right? So the wall is moving in a little bit closer up here than here. So this would maybe potentially be an example of apical ballooning in some patient that might have Takotsubo. But other than that, you can appreciate in an ideal apical 4-chamber view, the movement of both the free wall and the septal wall as it moves inward, and the cavity size changes with contraction. And the subcostal view, I would say I probably use the least in terms of assessing LV function. I guess the one time I would say I use it is if the patient's body habitus, or for whatever other reason, it's very difficult getting parasternal or even apical four-chamber views. But this provides an additional four-chamber appearance where you can really assess, the LV function and size and compare it to the right ventricle size and function. You can see here, right, so the walls are thickening with contraction, right? The cavity size is shrinking. And this is probably indicative of someone with a somewhat normal EF. The other thing maybe to look at is if you are worried that someone has a reduction in ejection fraction, right, is to rotate the probe from this view counterclockwise 90 degrees and really looking at the IVC, right? So if the IVC is plump and the patient has a very reduced appearing LV function, but they're hypotensive, that could be indicative of a patient with cardiogenic shock, for instance. Or if someone has an EF of, a reduced EF and a plump IVC and they're short of breath, maybe their volume overloaded and might need some diuresis. So this is really just the rundown of LV function assessment at the bedside. Are there any questions regarding this? We're going to probably just start going through a series of clips, and then we'll discuss the clips as we sort of go through them. Okay. So with that said, I don't know, Angad, if we sort of set it up like this in terms of like multiple choice, or?
Yeah, it's exactly like this.
Okay. All right, perfect.
Actually, we have the options specified. A is normal, B is hyperdynamic, C is reduced, but you can see the options when I
Okay, fine. No problem. I'll change this for next time then. But yeah, so fine. We'll say A is normal, B is hyperdynamic, C is reduced, and D is severely reduced. Okay, perfect. All right. So just keep in mind it's the same answer choices for every clip. And basically what we're just going to do is we're going to see how you guys do and what you guys think, and then we'll discuss. All right. If you get 100% right every time, then there won't be that much to discuss, but we'll see. All right. All right. And so let me see here. All right. And maybe as you guys are sort of answering the poll, if you guys, someone could tell me what view we're looking at here.
I think Andrew's saying apical for angioedema.
Excellent. Excellent. All right. And then I don't know, I mean, we have like 53 participants, so I don't, if we can see like how many people have answered, or.
Yeah, 29 have answered.
Okay. Let's see if we can bring it to 40. Let's see.
Okay.
It's anonymous. There's no pressure, guys. So.
Yeah. I'll declare the poll start at 40. Yeah, 33. Very good. Keep going, guys. Almost there, 37. I think we've 38. Yeah. Okay. Should we just close it here? 38.
Yeah, that's fine. Yep. All right. And then can we actually see?
Yeah.
All right. So we have like I would say a mix between reduced and severely reduced. Okay. All right, good. So I'll let you guys, maybe what we'll do is we'll run through a couple other clips, and then we'll see, if there's like a pattern where you guys are getting caught off guard between some more than others. But I agree, it is definitely not hyperdynamic, right? All right. So then let's just we'll go through the next clip, and then we'll see from there.
We have 21 responses.
Okay.
31. Good. So we're at 36 now.
And then I guess, can anyone tell me what view this is?
Fatma says parasternal long.
Yeah, sorry, I just get rid of this. Okay. And then we want to end the poll.
Yeah, all right, 39 responses. And these are the results.
All right, so this is more disagreements, which is great. You know, it shows that, you know, this is the challenge that we face sometimes, right? So, you know, this one's tricky, I would say, but it looks like the majority was deciding between normal versus reduced. So I guess, can someone, huh? EF 40% is what I heard. So, you know, I think with one of the main things to look at, so I always look at, especially in the parasternal long axis view, is I kind of focus my attention on the anterior leaflet first. And I really try and see, like, is it going up towards the septal wall? You know, obviously we don't have end mode, so we can't measure it precisely. But to me, this maybe just maybe touches the midway point. You know, I don't think it goes much beyond the midway point, and it definitely is not touching the septal wall. If it was probably touching the septal wall, it would make me think that maybe it was hyperdynamic. And then I try and look at the squeeze here, right? And, you know, there is maybe some thickening, but overall the cavity size is not changing that much with contraction. So this is a patient I'd probably say has reduced LV function, whether you want to say mildly reduced or not, but it's not necessarily to the point where I would be worried for severe reduction. And it's certainly not hyperdynamic, but I can see why maybe, you know, some people would be thinking that this could be normal as well. Okay. What about this one?
So 36 responses. Should we give it another 10, 15 seconds?
Yeah. And what view is this, guys?
So we have 2 responses. Fatma says parasternal short.
Yep. Excellent. Yep. Good.
All right. 38 responses. We can end the poll. Fairly.
Wow. All right. Excellent. All right. No need to discuss this further. I agree. I agree with everyone's assessments. You know, I think as you'll find, you know, I think hyperdynamic might be one of the easiest things we could sort of figure out. And usually, you know, it'll be most commonly seen in someone with, you know, something like septic shock or even like hemorrhagic or hypovolemic shock. And so it'll be clinically apparent, but this will sort of provide better definitive evidence that maybe the patient needs resuscitation. So excellent. All right. So no argument there. The one thing I would say is in terms of the view is ideally, you know, this is probably a little bit closer towards the apex. At the end, it sort of gets the papillary muscles in there, but I think so it may be overestimating in terms of our hyperdynamic appearance just because we're getting closer to the apex. But I think the point of this clip was to show you hyperdynamic. All right, excellent.
Right, 23.
And then the view, guys, let's do this. I mean, I think it's kind of, you guys know all this, but, you know, just, yeah, so you want to be able to tell, you know, basically what's the closest to the probe, right? And so the closest to the probe is the left ventricle apex. So this is your apical four-chamber view. Yeah.
35 responses. 36. Okay, I think we can end it.
All right, so 23% normal, 49% reduced, and 28% severely reduced. Okay. So, you know, I think as you guys are going to get more and more comfortable with doing this, I think that the sort of the hardest determinants, right, is you can kind of, it's easier to see the extremes than sort of the not extremes. So the answer to this one I can say is that it's mildly to moderately reduced. And the reason why we're saying that is, you know, that there is some movement, right, of the septal wall. We're not getting the best view of the free wall, but overall the cavity size is not really shrink significantly with contraction. So maybe that would be suggestive of at least some reduction in LV function. But I agree, it can be very challenging to really delineate. You know, whether it's severe or even, you know, potentially thinking that this could be normal. But that's why, you know, we wanted to sort of do these series of clips just to get you guys more familiar and comfortable, so that, you know, the more you see, the more comfortable you get in estimating the function. So that being said, and what view is this, guys? Yeah. And I do have to give a shout out to this person who's donated most of the clips. So he's actually a fellow of the fellowship even pre my time. So a lot of these clips are from, I think, 2013, 2014, but they still have a utility today. But hopefully, as more and more of you guys do the ultrasound elective, I'll be taking more and more of your clips. But yeah, this is a
38 responses.
Excellent. All right. So it looks like, you know, most of you guys said severely reduced. Yeah, and you know, the main thing with this one that it would probably do is just contrast with the clip that you saw at the last question, right? And so I think compared to the last one, the function here is definitely even a little bit worse. There's some movement, but I would say the cavity definitely doesn't go anywhere near a third inward, right? And there's really not much of a difference in terms of the cavity size with contraction. The walls don't really thicken significantly either. So this is a patient I would say is severely reduced function. So excellent. And so what view are we looking at here? Yeah, subcostal. And you can tell, right, because this is sort of the liver up top, that's sort of, you know, our acoustic window for the ultrasound. And then the first thing the probe meets is or the ultrasound rays meet is the right ventricle, and then the left ventricle is down here.
Thirty responses. People a little slower on this one.
Oh, it's thinking.
Yeah.
And, you know, I picked this clip because it's kind of the reality of what some of our views are, where, they, you know, we want our subclassical view to be a nice, pretty 4-chamber view, but obviously this is sometimes the best we can get. So we just have to make our estimates with what we can see.
Last 5 seconds. Just pick something.
Yep.
Okay.
Okay, so yeah, you guys were deciding between normal and hyperdynamic. And so, you know, I think part of the challenge is, right, is the view, right? So I would just try and focus, you know, in something like this with the apical 4 subcostal 4-chamber view. You really want to pay attention to the cavity size with contraction. And, you know, I think, you know, it's hard to say because it's a little bit off axis, but the cavity is almost completely obliterating. So this is a patient I would probably classify as hyperdynamic. And then, you know, especially since you're already in this subxiphoid subcostal view, this is a patient I would just go right away and look towards and try and find the IVC. If the IVC is like super collapsible or essentially non-existent, that would probably go more in line with what my thought was, that this patient has hyperdynamic LV function. But I think this view is not ideal, obviously, but that's how I would sort of classify it. All right, what do we think about here? What view are we looking at? And and I guess they gave you some information that this patient is on Leaflet. Yep, this is the parasternal long axis. Excellent. So you have your right ventricle outflow tract up here, correct? And then your left ventricle is over here. Aortic outflow tract here. Left atrium is here.
Ten more seconds. Right.
All right. So 66% said normal, and then some said 23 hyperdynamic, and then a couple said reduced. So yeah, so this is, you know, we've asked a few clips and we haven't presented any normal ones. So this, I wanted to throw that in there. You know, that sometimes when we're doing point of care ultrasound, right, we want to try and find things that are sort of abnormal or wrong with the patient. But, you know, sometimes there is, you know, pertinent normals, right? And so this would be an example of someone who has likely normal ejection fraction. You know, I agree, you know, I could see how some people maybe thought, you know, hyperdynamic just because, you know, the anterior leaflet almost touches completely the septal wall, and the cavity maybe shrinks in at least a third, maybe a little bit more than that. So, but this is someone who ended up having an echo later in the day, and it was a normal ejection fraction. Sometimes also, you know, it's hard to say whether the Leaflet might be playing a role in what we're seeing, but if the patient were on Leaflet, but yeah, so this is a classic, someone who had classified as normal function. All right, well, this is not the best view, but what are we trying to look at here? Yep. So this is supposed to be your apical 4-chamber, right? So you have your left ventricle right here. You can see the mitral valve pretty clearly, and then this is your left atrium. And then you sort of have to imagine that the right atrium's around here, and then the right ventricle is here. So this is not something that we would be able to, you know, estimate RV size or function, but, you know, the question is what we can say about the left ventricle function here.
Right. 31 responses. Let's give it 10 more seconds. Right.
All right. So a couple said normal or reduced, but the majority said hyperdynamic. And, you know, I would sort of agree. If you look sort of at the the cavity, right? So the cavity is right here in the center. You can kind of see, it's a little bit gray, but you can kind of see that with contraction, the patient's probably tachycardic, that the cavity completely obliterates and the walls sort of, the septal wall and the free wall sort of touch each other. And so this is a patient that I would classify as hyperdynamic. Of course, this is not an ideal view, and I'd want to see more, but that's what we can begin to tell from this. Any questions about any of these so far? I have a few more examples, and I suspect, as we get more practice with them, that, your percent correct, I think has already started to improve significantly. So. All right, and what are we looking at here? Excellent, you have parasternal lung, right? So you have your right ventricle outflow tract up here. This is your aortic outflow tract, the aortic valve right here. This is your LA, and then you have your mitral valve here as well. And then this area is the left ventricle.
33 responses. Past 10 seconds. Right.
All right. So there's some normal, one hyperdynamic, and then some reduced, and then it looks like the majority said severely reduced. So I agree. I think in this case, it's probably severely reduced, and I can replay why. So if you look, right, so the main things to look at again for the parasternal long axis are how well the walls are thickening with contraction. And, we can kind of see it here. There's not much difference in diameter with contraction. How much the cavity size is shrinking. And again, there's not much change. And then, the easiest thing that I think to look for is the movement of the anterior leaflet of the mitral valve. And again, you want to at least go past the midway point and almost touching towards the septal wall for us to think that maybe it's normal hyperdynamic. And I would say in this case, it doesn't get to midline. And, midline would probably be closer to here, and then maybe just goes a third of the way. So this is a patient that I would classify as severely reduced. All right, and then what do we think about this clip? And then, so what are we looking at here? What view, I should say? Yeah, so I would say this is a bit of an off-axis apical four-chamber view. I know sometimes it can look like subcostal just because the right ventricle looks like it's on top. But my guess is that maybe the person handling the probe was a little bit in the wrong location. And I guess, obviously this lecture is about LV function. Is there anything else that that's piquing your interest or maybe thinking something's abnormal? Yeah. So, the RV, right? So in typical right ventricle, it should be less than 2/3 the size of the left ventricle. And in this view, I agree. I think it's at least the same size, if not bigger. So I'd be definitely concerned for RV dilation. And then I'd want to get a better view, and we'll probably talk about it in a future lecture, but I think there could potentially be McConnell sign where essentially you get, with like akinesis of the lateral wall, you get sort of what looks to be the hyperkinesis of the RV apex. You get sort of like a bouncing in of the RV apex. So this is some patient that I'm worried about has some some RV dilation, but the question is whether or not the RV function is preserved or not. I probably want to get a little bit better views. But that being said, we'll stick just to the left ventricle for today. And so I just wanted to hear what your guys' thoughts on the left ventricle.
We just have 29 responses for this one. And let's give it 10 more seconds. All right. Okay.
Yeah, excellent. So I think the majority of you guys said hyperdynamic, and I would agree. I think obviously we'd want to get other views of the heart, but based on what we're seeing here, you can again see the cavity, right, with contraction. The septal wall and the free wall sort of basically a butt touch up against one another, and so that might be suggestive of hyperdynamic function. That being said, you may, depending on what's going on with the right heart, you may be cautious about aggressive fluid resuscitation or further workup and management, depending on what the clinical scenario is. And what view are we looking at here? Yep, agreed. So it's the parasternal. 30%. It's parasternal short axis, right? So you have your left ventricle here, and then you have the right ventricle up top up here, sort of looking like a crescent moon shape, and this is the septal wall.
Right, 31 responses, 15 more seconds. All right.
All right. So yeah, so I would say the majority of you guys ended up going with reduced, and then a good amount said severely reduced. I think it's tricky, right? So you may think that something doesn't look normal. It's sort of just a question of whether you think there's enough movement for it to be mild or moderately reduced, or not enough movement where you can want to say severely reduced. I would think in this instance, again, for parasternal short axis, you want the left ventricle like radius essentially to decrease by a third, at least a third, to denote normal ejection fraction. And I would say it doesn't do that here. That being said, there is some movement and contraction inward. So I'd be hesitant to call it severely reduced. So I agree with the majority of you that this is probably at least mild and moderately reduced. And what view are we looking at here? Yep, subcostal, right? So this is like more of our used to, where you have the right ventricle up here, you have the right atrium here, and then you have the left ventricle and left atrium. And then we're not really seeing the liver, but usually the liver, you'd probably see at least a little sliver of the liver as part of the acoustic window for the probe.
Four responses. Last 10 seconds.
All right. Yep. You guys are getting better and better. Yeah. So I think, obviously you guys were correctly able to determine that something was not normal, right? So again, the question is whether you think the walls are contracting at least a little bit or really not much at all. And I would say in general, if you look, you can see the cavity fairly clearly here, and the septal wall is delineated, and there's not much change at all with the cavity with contraction. So this is someone who I would classify as severely reduced. All right, so we'd have maybe 3 or 4 more clips. Hopefully we'll finish soon. And then what's our view here, guys?
Who's telling us the view? Yeah.
UNSI. Yep. Parasternal long, right? So you have your RVOT up here, right? Your aortic valve here, your mitral valves right here. And then I think what's good about this view, which we haven't seen in some of the other ones, is you can see your descending aorta. And this is important because if you see fluid above it, it's usually suggestive of pericardial effusion. If you see fluid to the side of it or below it, it's usually a pleural effusion. So it's always important if you're looking at a parasternal long axis to try and get the descending aorta at the bottom of your depth, bottom of your screen.
"26 responses. We have another 15 seconds.
All right, so 63% said normal, some said hyperdynamic, and then some said reduced. So again, I think this is probably not an ideal view, right? So you're really not seeing most of the left ventricle, but so you sort of have to sort of make assumptions or make guesses from what you have to work with, right? So the main thing that you have to work with is the anterior leaflet of the mitral valve. And you want it to at least go past the midway point for it to delineate normal function. And for me, it definitely goes past midway. It doesn't actually touch the septal wall, so it may not be to the point where it's hyperdynamic, but I would say it's at least normal. And you can kind of see, you can see how the RVOT is contracting, but you can kind of make out a certain aspect of the septal wall movement with contraction. So this is a patient who did end up having normal function. And I think, again, normal is going to be the hardest thing to diagnose on a bedside ultrasound because we want to find abnormalities. All right, and then what type of view do we have here? Yeah, contrary to what this is saying here, we are not in the abdomen. This is another view of the heart. Yep, and I agree, it's the parasternal long axis view. It's probably a little bit off axis just because in terms of the location of all of the typical anatomy. But you have your RVOT up here, your aortic valve, and then you have your mitral valve coming in, and then this is part of your LA. And I think it's hard to see, but I think this is probably your descending aorta over here.
"24 responses. Guys, come on.
They're losing steam.
Yeah. All right, we can definitely touch 30. You have 25 right now. All right, 27.
Okay. All right. But yeah, I think you guys are getting pretty good. So in this case, again, it's I would call it hyperdynamic. And as opposed to the last clip we just saw, right, where the anterior leaflet goes towards the septal wall but doesn't actually touch it. For me, the anterior leaflet here basically touches the septal wall. So it would be suggestive of something that's hyperdynamic. And then if you needed extra evidence, you could sort of look at the cavity, right? And so as the walls are contracting, the cavity gets completely obliterated, right, and disappears. I think part of it could be because the axis is a little bit off, but I think all these signs are pointing to a patient with a hyperdynamic LV function. I guess, it's 4 o'clock. I think we can probably stop there. There's only 2 more clips, and I think it's, you guys have gotten a lot of examples. But, I will say the point of this is sort of just to get you guys familiar and with evaluating these things at the bedside. And, unfortunately with Zoom, it's kind of hard to really get you guys to practice. That's why I sort of instilled these clips in there just to get you guys engaged. But if you guys, obviously this is the first time we're doing something like this. So I would appreciate, you can talk to me or the chiefs about, in terms of feedback, what was good, what wasn't, in terms as we continue to try and implement some of these lectures into the academic half days. That way we can try and tweak things, make things a little bit more interesting or more engaging. All right. Yeah, and then thanks, Rafa. He sent some of the POCUS resources that are on the Chief website, which you guys should definitely try and take a look at whenever you have a free moment.